You can enter your questions in the chat at the end of the presentation. And please just remember to fill out a questionnaire at the end of Grand Rounds. Let us know that you were present today. So I'd like to introduce our speaker, Dr. George Thanassoulis. He's known to many of you, a friend and colleague in cardiology. Dr. Thanassoulis is Director of Preventive and Genomic Cardiology at the MUHC and Professor of Medicine at McGill. His clinical interests are in cardiovascular prevention, dyslipidemia, specifically lipoprotein A, and premature coronary artery disease. He currently runs the MUHC Family Heart Clinic for patients with premature CAD and their families with the goal of optimizing their preventative care. His research interests are in the genetics of aortic valve stenosis, where he leads an international consortium investigating the role of genomic variation in this disease. This work has culminated in the recently launched CAVS trial that will evaluate the role of targeted lipoprotein A lowering in aortic stenosis. He is also working on developing new approaches to optimize cardiovascular prevention in young individuals. And he is the co-chair of the 2021 CCS, so that's Canadian Cardiovascular Society, Dyslipidemia Guidelines Committee. So it's a great pleasure to have with us today Dr. George Thanassoulis, who will talk to us about innovations in lipid management. George, thanks for being here.
Thanks so much, Nadia, for the introduction, and thanks again for inviting me to speak at Grand Rounds. Always a pleasure to be among colleagues here. So as Nadia mentioned, I'm going to try to give a bit of a summary. I keep mentioning this when I give a talk like this, that 10 years ago, I was told that preventative cardiology was dying and that we had statins and there's not going to be very much more for us to do, and it wasn't a great field to go into, and I should be like my interventional colleagues, put stents or defibrillators. But happily for myself, I guess, and I guess for patients, there's been major innovations in the way we manage patients, both before their first heart attack and after their heart attack. So we have lots of new therapies in preventive cardiology and more on the way. So I'll get started. I see people keep coming in, which is great. Let's see if I can move the slides. These are my colleagues of interest. So the goal today is really to very briefly go over the importance of LDL cholesterol, which I think everyone is aware of, and maybe touch a little bit upon apoB, which many of you know has been Alan Snyderman's, the focus of Alan Snyderman's career, and I've been swept in that as well. And discuss, as I mentioned, some novel therapies in lipid management. Talk a little bit about RNA antisense technology and siRNA technology, since these are new approaches to manage lipoprotein disorders, and also to provide an overview of these new molecules for dyslipidemia. So this is a case, as Nadia mentioned, I have a clinic where we see young patients who've had an MI, and this actually, this case came to me in a sort of circuitous fashion. I actually do stress tests at the Queen Elizabeth, and this patient was referred actually from the emergency room after a visit for atypical chest pain for risk stratification. And he was a 34-year-old gentleman. He had a past medical history that was very significant for a myocardial infarction in 2021, so when he was 31 years old. And at that time, he had a PCI of his LAD. He also had a 50% circumflex and a 50% RCA. And he also curiously had pancreatitis in 2014 at a young age. When I inquired about his family history, it was very significant. His father had an MI at 70, and his mother had a fatal MI at 55. And his sister also had dyslipidemia. So, after his stress test, I told him right away that this was not the place for him to be. He wasn't just a typical, post-ER atypical chest pain consult. He should be seen by our clinic in the prevention center. So we got a lipid panel, and his LDL came back at 2.8. His non-HL cholesterol at 3.2. his triglycerides at 0.74, HDL at 1.2, and he had an LPA that was sort of off the threshold here that we have at the MUHC of more than 1,700. And we'll talk about LPA in a little bit. And he was already on aspirin 80, atorvastatin 80, and ezetimibe 10. So the first thing, of course, in a patient like this is to realize that, first of all, they're undertreated. They're very young. They've had an MI, and they have significant coronary disease that's remaining. And when you look at their levels, you can be misled and think that this is a relatively benign lipid profile, although partially treated. But I think Dr. Genet has made a very good point that we need to consider what would the baseline LDL cholesterol be in this individual before they were on atorvastatin 80 and ezetimibe 10. And therefore, if we think about that, this patient likely had an LDL cholesterol that was certainly above 5, probably close to 6, and likely fell into that category of someone who likely has a genetic dyslipidemia. So we had a diagnosis of a probable heterozygous FH patient with a concomitant elevation of LPA in the 99th percentile. So this patient is at extreme cardiovascular risk. We confirmed the diagnosis by DNA sequencing. He had a deletion of the first exon of LDLR, and this was a pathogenic mutation. And of course, we instituted treatment for this patient with a PCSK9 inhibitor because, as I mentioned, they were only partially treated, and they're going to be randomized in one of the LPA lowering trials for that extremely high LPA level. So I think, the combination here is that this patient has both a genetic dyslipidemia, a monogenic disorder of familial hypercholesterolemia in the heterozygous form, and also has another genetic abnormality, which is this extremely high LPA, and likely both of these dyslipidemias have led to his extremely early and severe coronary disease. So I think the data now is extremely clear that LDL cholesterol and really all apoB lipoproteins are causal in atherosclerotic cardiovascular disease. And we have data really coming from a number of different studies, starting with epidemiologic studies and studies looking at individuals with hereditary disorders that really drive home this point. And over time, we've now complemented that with Mendelian randomization studies, and of course, randomized controlled trials that have all very clearly indicated the importance of apoB lipoproteins in the atherosclerotic process. And I think one of the most interesting things about this area is how tight this relationship is between LDL cholesterol lowering and cardiovascular events. On this figure, we see almost every trial that's ever been done in the cardiovascular space. And you really see how these trials, when you line up their LDL cholesterol lowering and their event rates, you have a very, very tight linear relationship between LDL cholesterol lowering and cardiovascular event reduction. And this leads to what I now call the cardiovascular constant, which is like the gravitational constant that says that for every 1 millimole reduction in LDL cholesterol, you're expected to have a 20% reduction in cardiovascular events. And it's remarkable that this really holds in almost every single condition, and we see this really at any level really of LDL cholesterol. And we have data now suggesting that there's really no threshold effect, and this continues to extremely low levels. So this has, of course, allowed us to move the needle a little bit in terms of how we manage patients in the post-MI setting. This is straight from our 2021 dyslipidemia guidelines, where we have now established new thresholds for the management of LDL cholesterol in patients who have had a cardiovascular event. And really, just to summarize this, what we've said is that if the LDL cholesterol remains more than 1.8, then this patient really should have additional therapy. So most of these patients will, of course, be on statin therapy. They should be on the maximally tolerated statin dose. And if they remain above 1.8, we really should be intensifying therapy. We've also provided the equivalent apoB and non-HDL cholesterol thresholds because, as I'll show briefly, we think those are actually more important than LDL cholesterol. And the strategy now is very, very simple. Basically, once they're on their maximal tolerated statin dose, the next step would be to add ezetimibe to a patient who is above these thresholds. And if they remain above the threshold with ezetimibe, then we add a PCSK9 inhibitor. So that's really the process in optimizing apoB in these individuals. So I just want to talk a little bit about apoB, and I know I've talked about this before, and Dr. Snyderman has as well, so I won't spend too much time on this, but I did want to just, again, highlight some of these points because I think they are very important, and we're clearly moving towards considering these alternate markers like non-HDL cholesterol and apoB in cardiovascular prevention. So I think the key point with respect to apoB is that all apoB lipoproteins are atherogenic. And that's why knowing the concentration of apoB really gives us an idea of the concentration of atherogenic lipoproteins in blood. Now, obviously, for many years, we focused on this single atherogenic lipoprotein, which is LDL cholesterol. We know now that there are a number of other particles that are also atherogenic and that have perhaps not been as focused on in the past. We now want to move towards considering these other particles as well. The simplest way to do that, of course, is to use the non-HDL cholesterol. And why do I say that's simple? Is because it's available on every lipid profile. What it consists of is basically the measured total cholesterol, and from the total cholesterol, we subtract the HDL cholesterol, which is a non-atherogenic particle, and therefore we're left with basically a measure of the cholesterol content on all the atherogenic particles. And that gives a good measure of the overall burden of atherogenic particles in the blood. The problem with that, of course, is that when we're using a cholesterol mass, we're trying to use that cholesterol mass to determine how many particles are present. And of course, the problem with that is that the cholesterol mass within a particle, and even at different times, can vary significantly. So you don't have a very tight relationship between cholesterol mass and particle number, and that's why the apoB marker is superior, because apoB, there's actually one apoB molecule for every atherogenic particle. So that does not vary. That relationship is always constant. It's 1 for 1, and therefore a concentration of apoB is really a concentration of atherogenic particles. So you see that here, cholesterol can vary significantly in the different particles, but apoB, it's a 1-to-1 relationship, and that's why apoB really is the superior measure. So when I speak to people about how you should use these different markers, the apoB really takes priority. The non-HDL cholesterol is a good second place if you don't have the apoB, and then really if you don't have any of those, which is unlikely, you can use the LDL cholesterol. Now, we've done some work, and Dr. Snyderman has done this for many, many years, looking at discordance between apoB and non-HDL cholesterol. And what we mean by discordance is, can the non-HDL cholesterol accurately give you a sense of what the patient's apoB is or their particle concentration. And we did this in the UK Biobank, and we asked the question, for any given non-HDL cholesterol, how tight is the relationship with someone's apoB level? And what you can see here is that for any given non-HDL cholesterol, there's substantial variation in apoB at any threshold you select for non-HDL cholesterol. And just to give you an example, for example, let's say we use a non-HDL cholesterol of 160, which in the US, for example, is a threshold that's considered a high non-HDL cholesterol, and that could be considered for therapy. This represents the 42nd percentile in the non-HDL cholesterol distribution. But if you compare that to apoB, it can range anywhere from 88 to 112 depending on the patient, and that means the distribution would be anywhere from the 22nd percentile to the 63rd percentile. So you can just see that non-HDL cholesterol is not a great predictor of what the apoB will be in a given individual. We also went on and said, okay, well, yes, there is this variability, but does it matter if you have the apoB or the non-HDL cholesterol if you're predicting risk? And what we showed here is that if you know the apoB and you have both apoB and non-HDL cholesterol, we created a residual of non-HDL cholesterol, which is basically the information that's not seen in the apoB, so that the information that is sort of discordant. And what we see here is that apoB is a predictor of cardiovascular events, but if you add the information from non-HDL cholesterol, it really adds nothing. However, the converse is not true. If you have the non-HDL cholesterol, adding the information from apoB actually remains significant and therefore adds information to your prediction. So basically, all of the information you need is in the apoB, and even if you focus on non-HDL cholesterol, you will still lack a little bit of accuracy in your prediction based on the apoB information. So based on this, we've made this recommendation in these last guidelines where we said that any patient with triglycerides more than 1.5, we should really be using non-HDL cholesterol or apoB. And I think this recommendation was really a first step towards this idea that non-HDL cholesterol or apoB be the preferred marker for cardiovascular risk assessment. And we use this threshold of triglyceride 1.5 because in individuals who have higher triglycerides, what that does is that the triglycerides replace the cholesterol in some of the particles, and therefore those cholesterol particles become cholesterol depleted, and therefore that further disturbs the relationship between particle number and cholesterol, and therefore in patients who have cholesterol depleted particles, these other markers like non-HDL cholesterol and apoB are definitely preferred. However, there is good evidence to suggest that even in individuals who have normal triglycerides, that apoB and non-HDL cholesterol can still be very valuable. And we actually examined this as well. This is in the NHANES data set. And we really wanted to establish, whether this cut point of 1.5 of triglycerides is really important for determining whether someone's going to have if we can capture all of the discordance in individuals who have high triglycerides. And what we showed is even in individuals with lower triglycerides, there is substantial discordance. We examined discordance by looking at an LDL cholesterol to apoB ratio. So patients who have a low ratio have cholesterol depleted particles, and you see clearly here that even in individuals who have very low triglycerides, you still have 21% of the population have cholesterol depleted particles, where an apoB measure would still be very, very useful. And we did the same thing for non-HDL cholesterol and apoB, and we saw the same thing. So I think what this is telling us is that triglycerides are not a good measure for prioritizing who should have an apoB measurement. Yes, it's true that patients who have high triglycerides are more likely to have discordance, but it does not necessarily select all of the patients who have discordance. So I think as we move towards apoB and non-HDL cholesterol, we really start to have to become familiar with the different thresholds that exist. So I think, physicians now are very comfortable with LDL cholesterol thresholds of 5 millimole to suspected genetic dyslipidemia, or 1.8 millimole, which means that the patient's lipoproteins have been optimally controlled. The equivalent values for apoB and non-HDL cholesterol are 1.45 or 5.8 for someone who's at very high risk and where we should be thinking genetic dyslipidemia. And for those who are controlled in secondary prevention, where we really want optimal control, we really need to get the apoB below 0.7 and the non-HDL cholesterol below 2.4. So I think the key point here is, why are we putting so much emphasis on getting our patients to very low LDL cholesterol? And I think we're now generating a lot of data to suggest that reducing LDL cholesterol and all apoB lipoproteins to very, very low levels really completely changes the vascular disease. So in this study, this is the Huygens study, where they looked at individuals with OCT and IVUS. These individuals were randomized to either placebo or evolocumab, which is a PCSK9 inhibitor, which really is a very potent LDL lowering drug. And using this technology known as OCT, we can actually see the amount of plaque. We can also measure the fibrous cap, and going back to the biology, the fibrous cap is what determines the stability of the plaque and how likely it is to rupture. And the first thing that was noticed is that when you do these kind of analyses, you see that when you've given someone evolocumab and you've lowered their LDL cholesterol to very, very low levels, you get a significant thickening of that fibrous cap. So what you're doing is you're actually transitioning plaques from potentially unstable to a much more stable phenotype. And of course, that translates to reduction in cardiovascular events. We also see regression of the atheroma, so there's actually plaque regression in these individuals who are at evolocumab. So lowering LDL cholesterol and apoB lipoproteins to very, very low levels actually has two beneficial effects. It regresses disease, and it also stabilizes disease, which are exactly what we want in these individuals. And this actually translates to very, very important cardiovascular benefits. So this is actually new data from one of the large PCSK9 inhibitor trials, the Fourier Trial, which actually stratified individuals based on their achieved LDL cholesterol on therapy. And it's interesting to note, because in our last guidelines we were sometimes criticized as to whether we were actually being too conservative by putting that 1.8 threshold for where we think patients are optimally treated. Based on these new data, you can see here clearly that if you're, this is patients who have a LDL cholesterol of 1.8, this is 1.4, and these patients actually have an LDL cholesterol that's below 1. And you can see the patients who achieve LDL cholesterols below 1 have a significantly better prognosis after their first MI than patients who have a higher LDL cholesterol. So again, this is non-randomized data. There's lots of caveats to this, but it certainly adds to the evidence that aggressive management of LDL cholesterol, perhaps even more aggressive than what we've recommended in the current CCS guidelines, might be appropriate, and perhaps even more so in a certain subgroup of patients, for example, patients who have recurrent events or other very high risk features. So again, something perhaps that will change in future iterations of our guidelines. There's data also now on how safe is it to have very low LDL cholesterol for a prolonged amount of time. This is data from the Fourier study. This is an open label extension. And really the goal here was to get a sense of what happens to these patients over many years of follow-up. Now in Fourier, there was 27,000 patients that were randomized to this PCSK9 inhibitor or placebo. They were all in secondary prevention, so in a post-MI setting. And the trial only went on for 2.2 years, and of course that gave us a very limited assessment of the relevance of this agent in cardiovascular prevention. So this was the Fourier Trial. Patients were randomized to either evolocumab, which is given every 2 or every 4 weeks, or placebo, and then patients could go from either of the arms into the open label extension and have their follow-up extended for another 5 years. So in total, some patients were on therapy for 7 years, and others were on therapy for 5 years. It's important to note that there's no actual placebo group in this open label extension. Really, the only difference is 5 to 7 years of therapy. The first, and I think most important point here, is that achieving very low LDL cholesterol was safe. So there was no treatment-related effects from being on evolocumab for a prolonged period of time. We didn't see any effects on, myopathy. There was no issues with diabetes, and there was no issues with hemorrhagic stroke. These are all very, very reassuring. When we looked at the prolonged follow-up, there was a 15% reduction in cardiovascular events. Again, I want to stress that there's no placebo group. This is really comparing, 7 years to 5 years of evolocumab. But again, it speaks to the point that at any point when you start this therapy, you will get benefit, and that benefit will persist throughout follow-up. I think an important point that was made, and again, in the initial Fourier analysis, there was no benefit of cardiovascular death in these patients. Again, it was only 2.2 years, but with extended follow-up going out to 5 years, we saw a very significant 23% reduction in cardiovascular death. Again, I think this speaks to the importance of maintaining very low LDL cholesterol and apoB in these patients for a prolonged period of time. So I just want to now talk about a second case. I think I tried to sort of summarize the data on apoB lowering using PCSK9 inhibitors and the thresholds for therapy there. Now, in the second case, I want to talk about some of the other factors that play a role in the sort of what we call the residual risk in an individual whose apoB lipoproteins have been well controlled. So this is a 53-year-old woman, again, a younger patient seen in my post-MI clinic for young patients. She had a acute coronary syndrome and had a PCI to an RCA. As you can see, she has a family history of premature coronary disease. She's been diabetic for 10 years. She's on metformin and EMPA. She has a very well-controlled blood pressure, body mass index, hemoglobin A1C. As you can see, her lipid profile also looks good. Her total cholesterol is 3.7, HDL is 1, which means her non-HDL cholesterol is 2.7. Her triglycerides are 2.6. Her LDL cholesterol is 1.5. So again, quite well controlled. And her apoB is 0.65. So this patient is really in that optimal level of apoB for someone in secondary prevention. But she has an LPA of 140. So when you look at this profile, the two things that should stick out to you are, one, she has a moderately elevated triglyceride and a very high LPA. So let's talk first about the triglycerides. What do we do about triglycerides in the post-MI setting? What about, do we use a fibrate in this individual? Should we use Icosapent Ethyl? What does the evidence say? So I want to just talk a little bit about this idea of persistent cardiovascular risk. As cardiologists, we often see patients who come back with recurrent events. The reason for those are not always clear, but there are a number of different reasons for, or mechanisms for, this recurrent event. And one of them, of course, is plaque instability, but triglycerides seem to play a role in this. Oxidation and inflammation are also key players, and of course the traditional risk factors, but also the non-traditional risk factors like LPA. So I just want to talk about the triglyceride risk, and this study was the Pemafibrate, the prominent trial with Pemafibrate, which is a newer fibrate agent used to lower triglycerides. Now, there's been a lot of data, and people were really interested in getting the results from the prominent trial, just because there's been a lot of controversy with the use of different fibrates for triglyceride lowering. Do they lower cardiovascular events? In sub-analyses of some of the trials with other fibrates, there seemed to be some benefit, perhaps in diabetics, perhaps with very high triglycerides. There was some potential evidence. So this trial was really defined to answer that question. Does triglyceride lowering in the perfect patient, the diabetic patient, in secondary prevention, actually there were some patients who were in primary prevention, but they were a minority, who has high triglycerides, who's already on a moderate or high intensity statin, does the addition of a fibrate reduce cardiovascular risk? And this was a typical cardiovascular endpoint-driven trial looking at a standard MACE outcome. So the first thing I want to say here is that these patients were very typical for clinical practice. They were in their 60s. They were very well treated with high rates of ACE inhibitors, statins. Actually, more than 70% or close to 70% of them were on high intensity statins, and they were also receiving GLP-1 and SGLT2 drugs as well. The addition of Pemafibrate, when we compared the active arm to the placebo arm, there was a 26% reduction in triglycerides. Pemafibrate is a very effective drug in reducing triglycerides. There was really no change, maybe a little increase in the LDL cholesterol. There was no change in the non-HDL cholesterol, and there was a minimal change in apoB. So very significant effects on triglycerides, and marginal effects on LDL cholesterol, non-HDL cholesterol, and apoB. These are the results, completely neutral, with really no evidence of any benefit from triglyceride lowering in this, as I pointed out, this perfect population where we should see benefit if such benefit existed. So I think this finally puts this issue of fibrates to rest. There is really no cardiovascular benefit from fibrates. And I think based on this data, I think it's fair to say that we should not be starting patients on fibrates for cardiovascular reduction. And if anything, we may be considering removing patients who are already on fibrates off of fibrates if it's just being used for cardiovascular prevention. I want to point out the only reason a patient should be on a fibrate in 2023 is for pancreatitis prevention in patients who have extreme elevations of triglycerides. We're talking about 10 millimoles and higher. I want to contrast the results of the Pemafibrate trial to the Icosapent Ethyl program, which is the Reduce It program. For those of you who don't know, Icosapent Ethyl is a prescription-grade, highly purified form of omega-3 fatty acids of the EPA type. So in the current 2021 dyslipidemia guidelines, we do not recommend typical fish oil supplements, which are made up of a mixture of a number of different fatty acids. Icosapent ethyl is a very different agent which is highly purified and only contains the EPA component. In the REDUCE-IT trial, we saw a very significant 25% relative risk reduction in patients who received Icosapent Ethyl over placebo in patients. Again, this was primarily patients in secondary prevention with a very small group who were diabetic and had other risk factors, so a high-risk primary prevention group, but the vast majority of these patients were in secondary prevention. And I think it's important to note, we don't see this very often, but we're talking about an absolute risk reduction of 5% in this trial. It's important to note that that IPE did not act via lowering of triglycerides. So this was not related to the baseline triglyceride level of the participants. It seemed to be consistent across all the LDL cholesterol levels, even in patients who had very low apoB, so a optimally treated patient who's below that close to that 0.7 threshold, you saw a very consistent benefit of Icosapent Ethyl. We don't exactly know how Icosapent Ethyl works. It's not via triglyceride lowering. It does seem to be related to the amount of EPA in the blood. As I mentioned, Icosapent Ethyl is purified EPA, and what we see is the patients who achieve the highest levels of EPA in the blood had the lowest cardiovascular risk. Why exactly does that happen? It's not entirely clear. It's believed that EPA may have anti-inflammatory, anti-platelet effects, and therefore may, in general, be an anti-atherosclerotic mechanism, like a direct anti-atherosclerotic mechanism that's really completely orthogonal to the typical mechanisms that relate to apoB, lipoproteins, and cholesterol deposition in the artery. So in this patient, who's otherwise well treated, whose apoB is low, this would be a reasonable option for this individual to consider IPE in the individual. Again, I just want to summarize. I think the management of high triglycerides in 2023, both in primary and secondary prevention, we should be considering them only to prevent pancreatitis in patients who have very, very high triglycerides, and these patients really should be referred to a lipid clinic because they may have, again, a genetic disorder. In that intermediate range in primary prevention, the therapy for high triglycerides is a statin if they have other factors and they meet the criteria for statins in primary prevention. And really in secondary prevention, it should be, they're all going to be on a statin, so therefore IPE would be potentially indicated. So what about LPA? So this woman had two different areas of residual risk. She had high triglycerides and she had a high LPA. So what should we do about the LPA? So just a few words on LPA. LPA is first of all my favorite particle. So I learned from Alan Snyderman that it's good to associate yourself to a particle, and he made a career on apoB. So I'm focusing on LPA. Hopefully that goes as well as Alan's career went. So LPA is a LDL-like particle. It's like the ugly cousin of LDL. It's basically an LDL particle, attached to which is this apoA protein. And it's believed that this apoA protein makes the particle perhaps a little bit more sticky, a bit more likely to enter the vessel wall, a little bit more inflammatory, and perhaps, the data is not entirely clear, but maybe a bit more prothrombotic as well. And therefore, it really touches on all the different aspects of atherothrombosis. LPA is a genetic abnormality, so having high LPA is determined almost entirely by the genetics that you've inherited from mom and dad. It's not modified by lifestyle or diet, and in fact, statins have almost no effect on LPA. The only agent that has some LPA lowering effect is a PCSK9 inhibitor. We used to say niacin. No one uses that anymore, but PCSK9 inhibitors do reduce LPA by about 20%. It's extremely common. So 20% of the population have elevations in LPA, which means about 6 million Canadians have high LPA. And the important thing is that most people don't know their LPA levels because it's only been a formal recommendation in the guidelines to screen for LPA as of 2021. So a lot of people are going to be finding out that they have high LPA in the coming years. We consider that there's increased cardiovascular risk when the LPA is more than 50 milligrams per deciliter or 500 milligrams per liter based on the units here at the MUHC, or 100 nanomoles per liter using a different assay, which is often seen in some of the private clinics. As I said, we're now recommending universal screening, so one-time measurement of LPA, and that's really to identify people who have extremely high LPAs. There are some individuals who have LPAs that are 3 or 4 times the upper limit of where we consider the threshold of high, and those patients have a prognosis that's very similar to heterozygous FH. So, lots of events starting at a young age, a bit like the patient I presented at the beginning of this presentation, who had both FH, but also had, an FH equivalent with an LPA that was more than 1700. And in these individuals, because we don't have currently available targeted therapies to lower LPA, what we're recommending is very aggressive risk factor modification. So, I tell patients who have this, you have a genetic abnormality that we can't fix, but what we can do is we can optimize all the other risk factors. So that means, obviously getting them to eat healthy and exercise, but also being very aggressive on their blood pressure control, their cholesterol management, their diabetes management, and really all the other cardiovascular risk factors. So whenever I talk about LPA, I have to say a few words about aortic stenosis. As many of you know, in 2013, we made the link between this unusual cholesterol particle and aortic stenosis. And of course, as you all know, we don't have currently a therapy for aortic stenosis. This was then, further looked at by our colleagues in Quebec City with Philippe Barrault, who showed that individuals who were at the highest level of LPA actually had greater progression of aortic stenosis, even when they had mild to moderate aortic stenosis at baseline. If you follow them over time, those patients would have greater progression, and of course, these patients went on to have more cardiovascular events, including aortic valve replacement. And there was a very interesting analysis that was done by the Fourier investigators in one of the PCSK9 inhibitor trials where they use evolocumab. Remember, evolocumab lowers both all the apoB particles, including LPA, so it leads to about a 20 to 30% reduction in LPA. And again, this was a non-pre-specified analysis. AS was not adjudicated by a committee. These are just sort of things that were noticed in the chart. So again, there's a lot of caveats to this analysis. But what they showed is that if you looked at the individuals who received evolocumab and who had very aggressive lowering of apoB and also some lowering of LPA, there was about a non-significant trend toward benefit with respect to reducing aortic stenosis. And as you all know, aortic stenosis is a very slowly progressive disease. So they actually did a landmark analysis where they actually said, well, let's exclude this first year and see what happens beyond the first year, where we'd expect these profound lowering in particles to have an impact on aortic stenosis. And when you look at that landmark analysis beyond 360 days, there was actually a significant 50% reduction in aortic stenosis with the use of evolocumab. So again, this is definitely not definitive. It requires a lot more work. It's food for thought. It adds to the evidence that perhaps aggressive lowering of apoB particles and LPA may eventually reduce the progression of aortic stenosis and perhaps one day avoid the need for surgery. So we are actually currently working to investigate that question with a LPA targeted therapy. This is a drug called Pelacarsen. It's one of these RNA antisense therapies, which is very, very, very effective in lowering LPA. We can see about anywhere between an 80 to 100% reduction in LPA levels. And this trial will investigate, we're going to be enrolling patients with mild to moderate aortic stenosis with high LPA levels, and then randomizing them to placebo or Pelacarsen to see whether we can slow AS progression. So in the last 5 minutes here, I'm just going to briefly discuss some of these RNA-based drugs. So I've already mentioned that we're going to be using one of these for apoA lowering, which is LPA lowering, but there are also other ones against PCSK9, apoC3, and ANGPTL3. All of these have different effects on different lipid and lipoprotein parameters, and they all really work by blocking RNA transcription and translation. One of them is another LPA lowering molecule. I mentioned Pelacarsen. This is an agent called Olpaceran. We're currently doing an RCT with Olpaceran here at the MUHC. This agent is a siRNA. So when they're siRNA, the key thing there is they last. The treatment lasts very long. So this can be dosed every 3 months. So we're talking about 4 injections a year. And as you can see from the phase 2 trial, we're talking about remarkable lowering in LPA here to about 100%. So we can normalize a genetic abnormality with these siRNA therapies, and then now investigate whether this will lead to improved cardiovascular outcomes and perhaps reduction in aortic stenosis. The other agent is Inclisiran, which is coming. It's currently available in Canada. We're still waiting for the outcomes data. This is, again, like a PCSK9 inhibitor, which is an antibody which removes PCSK9 from circulation and enhances the clearance of LDL and other apoB lipoproteins. Inclisiran is another siRNA, so it gets into the cell, it finds its antisense strand, so that would be the PCSK9 mRNA, and therefore it destroys this PCSK9 mRNA. By destroying the mRNA, you don't produce any PCSK9, so you basically remove that PCSK9 from circulation, very similar to an antibody, and therefore again increase clearance of apoB lipoproteins. With Inclisiran, we can get about a 44% reduction. As I mentioned, an siRNA therapy like this can be dosed very infrequently. For Inclisiran, it's actually every 6 months. So we're talking about 2 injections a year, and you can actually get people down to very, very low levels of LDL cholesterol and apoB. We're still waiting for this trial, which is the Orion 4 trial. We don't have any outcome data. It appears that this is a very effective therapy. It does lower LDL and apoB as expected, but we really want to see the results of this trial to see the evidence for reduction in cardiovascular outcomes. Just very briefly, Banpadoic acid is another therapy that's been recently developed. As you know, many patients have intolerance to statins. We don't have a lot of oral therapies to give them. We do have injectable therapies like the PCSK9 inhibitors, but having another oral therapy would be very, very useful. The way this works is, if you remember your cholesterol synthesis pathway, HMG-CoA reductase is where the statins work. It's one of the last steps in cholesterol synthesis. Well, ATP citrate lyase is actually an enzyme that's about 2 steps above from HMG-CoA, and therefore by blocking that, we get very similar effects to a statin. The advantage is that Banpadoic acid is a prodrug. It's actually activated in the liver, and therefore all the effects are in the liver, and therefore you get no metabolites in the muscles, and it's hoped that will lead to lesser muscular side effects that we sometimes see with statins. The use of Banpadoic acid led to about a 15% reduction in LDL cholesterol. So again, not particularly potent, but it is an oral therapy, and therefore it can be useful. And this trial was done in patients who were statin intolerant, and it did show a 13% reduction in cardiovascular events. So once again, another therapy that lowers LDL, that lowers apoB, and that again provides the expected reduction in cardiovascular events. Again, there was no side effects, and the key point here is no muscle-related side effects, which is really the raison d'etre for Banpadoic acid. As of 2023, this agent is not yet available in Canada. We're not sure whether the company's planning to bring it to Canada, but it certainly would be useful because we do have about, I would say 10% of our patients have difficulty in tolerating statins, and we often don't have another oral alternative to give them. A few words on obicetrapib. This is this is in phase 2. It's a CETP inhibitor. For those of you who've been following the cardiovascular area, CETP inhibitors were a big thing about I would say maybe 15, 20 years ago when I was a cardiology resident. And the goal of CETP inhibitors was to boost HDL. So we thought we'd had an agent that could artificially boost HDL, and this would give us the benefits that we saw that were associated with HDL. As you all know, those trials failed. We don't believe that HDL itself, the concentration of HDL, is a causal mechanism in atherogenesis. But a very smart cardiologist noticed that this CETP inhibitor, obicetrapib, which was designed for HDL boosting, also had very, very potent apoB lowering effects. And of course, it being an oral agent, he felt that perhaps this would be another oral agent that could be added to the therapeutic armamentarium for LDL lowering. And as you can see, it's very effective. This is on a background of statin. You can see that you get a very significant lowering in LDL cholesterol and also in apoB. And interestingly enough, you also see some lowering in LPA, all from an oral therapy. This is still a phase 2 data. The outcome trials are coming, and we're hoping to see both there's going to be a first trial in familial hypercholesterolemia, where there's clearly an unmet need, and some patients really can't get down to low levels with that condition, but eventually we'll also come to secondary prevention in patients who don't have genetic dyslipidemias. And the last thing I just want to mention, just to give you an idea of where things are going, there's now some data on CRISPR base editing, which basically is a type of gene therapy towards the PCSK9. So you can actually go in and just basically switch the base in the PCSK9 gene and see if you can shut down this gene and basically lower LDL and apoB. This has been done only in a few, I think this was done in monkeys, and you can see that you get very significant editing of the PCSK9 gene in the liver, and this leads to very profound lowering of LDL cholesterol. And we're talking about, this is a single infusion of drug, and this goes out to, as you can see, up to 480 days, and it's expected that this is going to persist forever based on preliminary data that the company's provided. So this, of course, would be what the company is calling a one and done. So you get one treatment and you don't need to have any further therapies. Your LDL cholesterol will be very, very low for the rest of your life. So again, we're going really towards less frequent dosing, less frequent need for therapy, and very, very aggressive LDL lowering in the future. So I'm just going to stop here. I think we're a little bit short on time, so I want to leave a couple of minutes for questions. You can all just read through my summary here, but I do really want to open this up for questions. So thanks so much for your attention.
Thank you, George. Wonderful lecture, as always. Excellent. Great to see this field evolving. We have quite a few questions. We have 5 minutes left, so it's going to be, if you can, 1 minute answers. In patients with type 2 diabetes, A1C 6.5, BMI 26, should a GLP-1 RNA antagonist be considered for vascular protection and weight loss?
I think definitely. I think that this patient should have more aggressive therapy of their diabetes, and certainly of their weight. BMI of 26. I'm ashamed to say I'm not sure if I'm there yet. But definitely I agree that the benefits of a GLP-1 beyond just the weight loss and diabetes control would be beneficial for this patient.
What about, can you comment on the primary prevention targets and apoB levels? What's your primary prevention target?
In prime prevention, we're saying that the threshold should be 0.8. So if you're above 0.8, you should have intensification of therapy.
The comment here about how can 20% of the general population have an elevation of an analyte? How are reference levels established in such a population? I guess he's talking about the LP.
Yeah, so that's a great question. It's not based on sort of a population. It's distribution. It's actually based on where the data suggests that the risk increases. So the risk increases at about 50 milligrams per deciliter or 100 nanomoles per liter, and that turns out to be about the 20th upper percentile of the population.
Any comment on the progression of calcium score with the use of statin?
Oh, that's a known phenomenon. We don't really understand it, but we know that you will have progression of calcification when patients are on statins. I think that a large part of that is what you're doing is you're actually stabilizing plaque and you're healing plaque, and that healing leads to calcification, and that's actually a good thing in patients who are on a statin. So I don't think that the fact that your calcium score progresses is necessarily a bad thing if you're on statin. I think we misinterpret what a calcium score really is telling us. A calcium score tells us that a patient has subclinical disease, and it's not the calcified plaque that we care about. It's the fact that patients who have calcified plaque also have a lot of soft and potentially unstable plaque, and that those are the ones that cause the event. So yes, when you put someone on a statin, you're going to convert some of that soft plaque to stable calcified plaque, but that's actually in the end, I think, a good thing.
Fantastic. 1 more minute. Is Icosapent available in Quebec for patients with private insurance?
It is available in Quebec for patients with private insurance. I think there's about, I was told recently that maybe 50 to 60% of them are now covering inclisiran, but it's a bit of a moving target, as you know, Yulia, because it's a relatively new drug. But yes, we do have coverage with private insurance.
George, Dr. Thanassoulis, thank you once again for an outstanding presentation, and wonderful, as I said, to see this field evolving. Lots of new data, and prevention is back and remains very important. Actually, it was never really gone, but we talk about it much more now, and that remains very important, obviously. There are questions and comments left, so I invite you to please, if you could continue to answer questions directly in the chat, if you can keep your Zoom connection open, but it will end the formal presentation. So thank you, George Thanassoulis. Wonderful presentation today, as always. Thank you for being here. And thanks, everyone, for joining us. You had a great audience of upwards of 120 people, George. So thanks for joining us, everyone. And I wish everyone a great afternoon.